Good afternoon, everyone, and thank you for joining us on today's webinar, Elevating Pediatric Readiness in Rural Hospitals. This is the fifth installment of our Handtevy Hospital Series, and today we're spotlighting pediatric readiness in rural hospitals across the U.S. I'm Daniel Moran, and it's my honor to welcome you. We have a fantastic lineup of speakers today with Dr. Peter Antevy, Dr. Barbara Walsh, Pat Bavaro, and Dr. Kerry Bachista. Together, they'll talk through a practical roadmap for low-volume settings. We'll cover readiness checklist, simulation you can implement immediately, and how EMS to ED collaboration can transform pediatric care. A couple of quick housekeeping notes before we get started. Please stay muted throughout the session to avoid background noise. But we do want this to be interactive, so drop your questions and comments into the chat. We'll be monitoring and responding as we go. Today's session is being recorded. So if time allows, we'll end today with a Q&A to dive a little bit deeper, and stay tuned for the end where you'll be able to claim a CE for nurses, EMTs, and paramedics. We're excited for what's ahead, so we're glad you're here. Over to you, Dr. Antevy.
All right, Dan, thank you so much. Everyone, thanks for joining. We have a great lineup today, and we have a really big announcement, which I'm excited to talk about at the end. Actually, I'm going to have Patrick on our team make the big state announcement. This is a topic that's near and dear to my heart, and you'll see why here in a minute. And I'm very privileged to have some great friends from around the country, around the state and around the country, who I've known for quite a while, who are truly innovators in this space as well. So if you're here today from a rural location, welcome. If you're here from a not rural location, welcome. At the end of the day, we all touch these patients, whether we are in rural areas or not, because if you're in the tertiary center, you accept these patients. If you're an educator, you're going out and educating folks to help with these patients. And that's what we're here to do and talk about today. So for those of you who don't know me, I'm Peter Antevy. I started off as PDR doc and kind of transitioned into EMS medical direction. And the stories that I want to tell are two stories, at least today, that don't make the news. One of them is related to me personally as a medical director, and the other one is from a story that was relayed to us by people who we know very well. So on the left-hand side, does anyone know where that is? It's so yeah, this is guess the map. So basically, this is Mount Graham, which is in Safford, Arizona. And that's a very rural place. And I'll tell you a story that happened in this location. And then I want you to imagine what you would do if you were there. On the right-hand side is Palm Beach County. And everyone thinks of Palm Beach County as, Mar-a-Lago or Billy Joel or all the rich people who live on the East Coast there. But I will tell you that Palm Beach County extends all the way towards Lake Okeechobee. And when you see that dot is one of the hospitals, a critical access hospital in my county, where I'm the medical director. And we have a couple of fire stations, 73 being the main one. There's 72, 73, 74, all sit out there. And when you go out there, it is a very indigent location, a lot of burnt out homes. Very, very little medical care exists out there. There's a prison out there where people are getting stabbed all day long. And if you want to have any semblance of a big tertiary hospital, you have to go all the way across. And that's an hour by ground. And so many times we're moving those people by air. So let's start with the first one. Motor vehicle crash. And two adults were ejected, the parent and the grandparent, unfortunately both deceased. Also ejected was a 2-year-old and a 4-year-old. One was unconscious, one was semi-conscious. These kids both show up at Mount Graham Regional Medical Center, where, and you can see the picture of it there at the bottom right. They're now presented with two kids who are sick and trying to die. They need blood. Both of them needed blood. Both of them needed an airway. And you're dealing with a critical access hospital. This just happened to be a hospital that we had implemented 2 weeks before. And Unfortunately, the two adults died, but we were so happy and thrilled to hear from Kyle, who called us from there, saying that both those kids walked out of the hospital. They had to be flown to Phoenix Children's Hospital, which is about a 45-minute flight. But you'll see in a minute what's based on the data, that what you do at your critical access hospital matters. It matters with outcomes, and it matters with how many patients ultimately gets transferred from your hospital. So it turns out that if you're a high quality critical access hospital, you transfer much less patients than if you were not high quality or well-trained hospital. And that's the story that we want to get into today, is how do you become that? How do you become that critical access hospital, that rural hospital, or quite frankly, that rural EMS system that people can depend on, even when it's critical, even when you need a chest tube, even when you need blood, even when you need to be intubated, even when you're septic, even when you have a medical illness that needs to be addressed by competent people, even when you have severe asthma that needs, magnesium, right? These are the things that we're talking about here today. And you don't need to have a PDR doc on scene or in your emergency department, but you need other resources to help you out. That's story number one. Story number two was personal. It was this was a very, very difficult moment, and we still have people at my department who have a lot of emotional distress from this call. This was a family who met for a family reunion in Naples, which was all the way on the west coast of Florida. And for some reason, their flight was out of Palm Beach County. So they put everybody in a van and they drove all the way across the state. Right when they got towards where the left side of the screen is here, in the middle of nowhere, rural Palm Beach County, they unfortunately didn't see the canal and they landed in the canal. Mm. This was a disaster, okay? Out of the 9 people, only 1 person made it, okay? So now think of this. You're on scene with multiple cardiac arrests, 6 of them who are children. You only have 1 helicopter, and you have ambulances coming, as many as we can get, not enough, putting more than 1 person in an ambulance, and all you have is Lakeside Regional Medical Center, which is a very rural critical access hospital with, not many people staffed there, right? So now you're making decisions, whether you're at Lakeside or whether you're the EMS captain or you're the paramedic or you're the captain on the engine. You got to be ready for this right now. And I hate to say this, but this is not just a one-off story, right? These stories never make the news, but they stay with people forever. They impact families' lives. And I always say hope is not a strategy. You can't just say, I hope this never happens to me, because it will. And the more rural you get, the more likely it is that you're going to have this bad day that could change your entire career. It could change your life. And the Children's Hospital, you could see, was way far away. Before I move on from this story, I will say that I'm so proud of my team who had the courage, okay, to go to that hospital where that 1 person was still alive, where nobody else would have done this. They went, and instead of anyone else telling them what happened to his family members, my team did that, right? My EMS captain, my EMS chief went to the bedside and cried with this guy and hugged him once he learned what had happened. So, this is not just about critical care medicine, critical access. It's not just about simulation. It's about caring for people. And at the end of the day, when you're in a rural community, everybody knows each other, and it is family, and you often do treat your own people. And so, as difficult as the story was, there is a little bit of a silver lining to knowing how people treated each other at the end of it. So really the question for today is, are you ready to treat these patients? Are you ready to treat the kids? Are you ready to treat the adults? And that's really what the discussion is here today. And it doesn't require a lot. And I'm going to show you that a paper just came out recently showing the amount of money it really takes, the amount of time it really takes. And that's why I have Dr. Walsh on here. That's why I have Dr. Bachista on here, because you don't have to go and buy the $100,000 mannequin. You don't have to go and, travel far and wide. No, there's some basic things you can do, and you can start treating kids the way they need to be treated. And that's what I want to talk about today, because most people don't know where Dr. Walsh and I trained and where she still works is what we call the ivory tower, right? It's where I thought for many years, all children come to the children's hospital. Yeah, not true. Most of them are not seen in the pediatric emergency department. And in fact, this was a very big story in the Wall Street Journal that exposed something that is still creating ripples today. And it's going to come to your town soon, which is that 14% of emergency departments are not even certified as being ready to treat kids. You would think that can't be true, but it is. And I'll show you the study in a minute. They also found that children are 4 times as likely to die in less prepared emergency rooms. Now, how do you know if you're in one of those emergency rooms? I'll show you in a minute. There's an online survey that people should be taking, or should have taken, or you could take today, and you'll get a score. And it turns out if your score is low, you'll have a very high likelihood of having increased deaths. And by the way, what we're trying to do today, what we're promoting now, is that we will help you become ready, right? That's what we've done for many years. Now there's a very nice roadmap, but you need people who have done it to help you along the way, and that's what we're here to do. 1,440 children died simply because people weren't ready. And again, the pictures of these kids on the screen were on the front page of the Wall Street Journal, who are no longer here today. Why? Because of lack of readiness. And for all of us who are in healthcare, for all of us who are parents, these stories are heartbreaking. And this is the sad truth from the paper, from the article. All ERs are not created equal. That's exactly what the point they're trying to make. And who got a hold of the story? Congress, legislatures at states, EMSC, researchers, clinicians, and everyone is trying now to understand, how do we fix this problem, this lack of readiness in EMS problem? How do we fix the lack of readiness in hospital problem? And at the end of the day, it ain't that difficult. We just we have to put people towards this problem, education towards this problem, money towards this problem. It's not just going to go away on its own. The New York Times followed it up in November last year, saying that 1 in 4 child deaths after ER visits are preventable. Okay. So once the mainstream media has this going, you know that more data will come and more research will come, and then laws will start to be passed. And that's what's happening now around this country. So when I say here, are you peds ready now? Here are 4 cases. I'm not going to push anybody on this call. I'm not going to stress you out. I'll let Barb do that in a little bit. But these are all cases that if these kids came into you right now, 7-year-old with leukemia and septic shock, you have 5-minute ETA. Think through what you need to do. These cases aren't that difficult if you've practiced, if you're ready, if you have the know-how. But what do you have if you have to transfer? Who's going to transfer? Do you have documents in place? Have you made a connection with those folks? Have you trained on the transfer, right? 5-year-old kid shot in the chest. That came into my emergency department unannounced. Okay. We need to intubate. We need a chest tube. We need blood. We need surgery. We need the OR ready. All that within seconds. Like you don't have time to figure that out at the moment. This is another rollover MVA, an 8-month-old actively seizing. When you think of these cases, you have to put them in practice. And one of the main reasons that I just love what Dr. Walsh is doing and why we're partnering with Dr. Walsh is because she comes into your emergency department and you see where you stand when she leaves. And it's a light that goes on that says, wow, I need to do other things here. And I don't have to buy the equipment. She'll just bring it in, right? Just some extra, norepi drip, chest tube, RSI, whole blood, 3% saline, Ativan, Keppra, CPR, and then a bonus. This happened to me at 2 o'clock in the morning one night. I had to pace a 10-year-old girl who had a heart rate of 28 with myocarditis. If you've never done that before, today's not the day to start. My history is that in 2005, when I came to this hospital called Joe DiMaggio Children's Hospital, and I came from, the ivory tower, I realized that, I was not in Kansas anymore, right, as they say. And so we just started going and doing sims and every month. And it took us time, but we became so good. And all the nurses you see in this picture, instead of running away from the code room, they all wanted to be in the code. Then we had to start kicking people out. It got too packed at the end of the day. So a couple of very important papers before I pass it on to my colleagues. When you look at your readiness level and how many patients you will transfer out of your hospital, it becomes very clear that if someone comes into your hospital and does an evaluation of you, just with on paper and just checking off some boxes, checking to make sure you have this and that, and we'll go through those in a minute, they can determine whether or not you will transport patients out or you'll keep them. It's that simple, right? And I'll show you what that is in a minute. So here we go. So for those of you not familiar with an odds ratio plot, if the variable crosses that dashed line at 1, then that variable is not significant. So you can see the only significant value that determined whether or not you would transfer a patient out of your rural hospital or not was whether you scored a certain score on your readiness survey. That's it. So the people who have done this readiness survey are super bright. I'll have a picture of Dr. Gashay-Hill in a minute, Dr. Kate Remick, Dr. Kathleen Adelgaze, and there's many others that I haven't mentioned here. They've perfected this. They now can tell you how you will do based on the survey. And so let's dive into it a little bit deeper. Now, a score of 70 is not that good, but that was the cutoff score where they said in this particular study for rural hospitals, if you're under a 70, then you have a 45% chance of higher odds of transferring patients out of your rural hospital or critical access hospital. That's a lot of patients. And I could tell you here locally in Broward and Palm Beach County, where on the non-rural places, you have urban hospitals transferring patients out because they're not comfortable with kids, right? Because they don't have the right training, they don't have the right people, they don't have the right policies. So yes, we're talking about rural hospitals today, but all of you on this call know what I'm talking about, that there are kids being transferred out of non-rural hospitals. Why? Because they don't have the people ready to manage, moderate asthma that doesn't need to be transferred. It just needs to be managed. Okay. This is another very important paper that I wanted to talk about, JAMA Network. And they actually looked into percentage of readiness in this population of 17.4%. They looked at how much it would cost to actually start to save lives. And I'm going to pick up this graphic here and look at your state. The number you see on the state is the number of dollars per person, per child, that it would cost to actually improve quality and save more lives. So we're here in Florida, $2.48 a person. The highest was North Dakota, $11.84 a person per year. It's nothing. It's nothing, right? The federal government now knows this, and that's why the federal government is saying, let's start giving money, especially to critical access in rural hospitals. But this goes to all states across all hospitals, that children's lives matter. And now we're finally seeing studies. So if you want to further this paper along, this is fascinating data. So just look at this closely. The white bar is the amount that these states are currently spending on readiness. And the gray bar is how much they would need to spend to reach high readiness, okay? And if you look at Delaware is the one state. So if anyone hears from Delaware, you should leave the webinar, because you're doing it well. Delaware is the one state that is already at where they should be. Everybody else kind of needs to spend money. And apparently DC has a little bit to go, but you can see that Delaware is the only state that's not required to kind of add more funding. So good for you, Delaware. Florida, we're up there. We do spend quite a bit on readiness, but we do need to spend quite a bit more. And then lastly, I found this graph fascinating from the same paper that the deaths, now the higher you go on the graph, the worse, right? So the blue dot is the number of deaths per million, number of children dying per year per million population in each state. So if you go to New York, it's the highest number of deaths per million. And then the arrow, sorry, the triangle, I'm sorry, is the number of deaths you would have if you were at peak readiness, right? So that's the arbitrage. So that's where you are today, sorry, in the blue dot. And that's how you can come down to just by adding a couple of bucks per person per year, you can start to reduce the number of deaths. And you can see Delaware again. I'm going to point out Delaware right here, where the arrow, sorry, I keep saying arrow, where the triangle and the blue dot are at the same place. It means that they're at the ideal place based on their funding. And why this paper came out and why it's so important, because it gave the signal that we have to put money into readiness. And with all the work that's been done on readiness already, the work is already there. So just real quick, I'm going to fly through this next section. But what is this PEDS Ready scoring system? If you haven't heard of it yet, this is Dr. Marion Gachet-Hill, legend in the field. She has a team of people. Again, Kate Remick is another outstanding leader in this field, Kathleen Adelgaze and many others, where they have created something that all of us have already probably done. But if you haven't done it, go to the website. You can call us. We'll help walk you through it. That's really what we're here to do. It does get complicated, and you do need to know what you're doing. You do need to know how to train, all the documentation, all the policies. We help you with all that. But basically, there's 175 items that someone at your agency or at your hospital needs to know what to do. Okay. Just as a few of them, just because these are some fun ones. They're simple. Are temperature, heart rate, and respiratory recorded on children? I mean, you would think, but they're not. Do you have things to measure blood pressure on all ages based on severity of illness, SpO2 and tidal CO2? Do you have a process to notify physicians when vital signs are abnormal? Simple, but again, it's something you need to focus on. Here's question number 52. Is there a process in place for the use of pre-calculated drug dosing in all children? That's what we have focused on at Antevy for a long, long time. Now we're doing much more. But as simple as this could be a game changer. So here are the scoring quartiles. And we order from Amazon a lot. I'm sure you do too. So I figured let's give it the Amazon star rating system, right? So if you take that test that I just showed you, the survey, and right when you're done, you press submit, it gives you a number. And then you know what quartile you're in. If you want to be a high performer, like a 4-star rating, you have to score 88 or above. That means you're a high flyer. And when the state passes a law saying, are you PEDS ready? That's the number they're going to be looking for. So here we are in 2025. I will tell you that every year that goes by, more and more states will start to say, to become certified, JCO certified, DMV certified, whatever certification, we require you to be at the highest quartile for pediatric readiness based on this peer-reviewed data. Okay, and here's why. Because the 4-star hospitals, when it comes to medical patients, save lives. When it comes to trauma patients, it's only the 4-star hospitals that show a difference in outcomes. So once you have a peer-reviewed study in these big journals by these big researchers showing that you have to get to a score, then you know what happens next. Get to the score, right? And that's why we are going to get you to the score. And that's why we've partnered with people like Dr. Walsh. And that's why you're going to hear from Dr. Bachista in a minute from the state level where the state is saying, hey, how do we fix this problem? So, and again, the last slide is the most important slide, which is this study. And more of these studies will keep coming out showing that the high quartile, the high flyers have the lowest mortality rate. And this is why the Wall Street Journal and the New York Times had their papers, is because of these data. Okay, so I'm going to move on because we're now going to talk about like the tactical part of the house, right? This is the room we love to live in the hospital. I love this room, right? If you love resuscitation, but most people hate the room. Well, how do you get to become friendly with this room and know all the ins and outs of the room? Well, you get the experts, right? So before I let Barb, I'll give you the wheels in a minute, but I want to brag on you for a second. That's okay. So Barb and I know each other for a long time. She, like me, has worked in the PDR for quite a while, but she's done a lot more, right? So she's dedicated her life to training, not just the ivory tower people, but she goes out to everywhere. Okay. And I was blessed to go out and actually observe Barb do this in real time. And it was so incredible. So has Barb published? Yeah, just a few papers, just a few papers. That's her. And then actually the July 10th comes up in a minute, but here's Barb doing her simulation. And then here's me. I was at a hospital. I took a little sneak picture. This was last month. And man, talk about engagement. I mean, Barb had people eating out of her hands, and it was such a great learning experience. I learned so much just watching her. So without any further ado, I'm going to stop my share. Dr. Barb Walsh, would love to you to tell everybody here and talk to everyone here about what have you seen out there. You train the biggest hospitals, you train the smallest hospitals, you bring the equipment, you do the training, and you keep going back and you keep going back. So We'd love to hear your take on things. Take it away.
Yeah, no, certainly. For time's sake, I was going to talk about sort of breaking things down into simple things, intermediate things, and complex solutions to these issues. I'm happy to delve right in for time's sake and talk about what I do and what COMET's about, if that is better. Just in terms of being very brief, I have gone all over. And the first thing I want to say to people on this call, I think we're all partners in care. And I look at all of healthcare as partnerships. We are on a continuum and we are on the same team. And I think that's how we need to view things first and foremost. I have the utmost respect for people that are in rural and critical access places. It is the hardest job. I feel like I am spoiled by working in an academic center. I'm at a safety net hospital, but still I have more resources than a lot of places. And so it starts with EMS in the field. It goes to a rural or critical access site, maybe to a community site, and maybe eventually ends up in my house with pediatric subspecialists. But the point is, we are all on the same team and to be working together for the best care of our kids. Simple things to start with, and I'm only going to say a few things because I want to talk about what I do and the impact of it. Having a pediatric champion at your site, a pediatric emergency care coordinator, is key. Someone that really is involved in and passionate about elevating the level of care for children really makes an impact. Simple things you can just think about. I'm going to be super quick. What are we good at in emergency medicine? We're good at our ABCs. You're getting a critical patient coming in. Take a breath. Review those ABCs. You got this. We're all well trained in that realm. Basic skills to think about and practice, and I mean this wholeheartedly. Simple things like practicing bag mask ventilation with a perfect CE hold. What's going to save someone in cardiac arrest? It's not our brilliant laminated algorithms. It's high quality CPR. Practicing it, making sure you're doing it the right way. Any kind of cognitive aid you can have at the ready in a binder, hanging on your code cart to offload any cognitive load is essential. And there are so many out there, and I can share those resources with you. Lanyards, simple things that you can do in a rural hospital, having lanyards that you put on when a resuscitation comes in so that all the roles are crystal clear and there's no confusion. I want to briefly say 70% of medical errors our communication. We know the medicine. We know how to do procedures. It's the system, it's the communication that can often be the barrier to the appropriate care. So figuring out how to make your system work for you. Is it organization? Is it the essential items? Is it how we maneuver them in the room? And that's sort of where I come into play. Couple quick things on the intermediate I just want to bring up. Phone a friend. I'm the biggest fan of phoning a friend. I've been practicing pediatric emergency medicine for 30 years. I don't know everything. Medicine evolves. We all are learning together, growing, evolving, and new technologies and things come out and change. Phone a friend, whether it is a local pediatric emergency medicine attending that you know from training with, whether it's your local pediatric ICU attending, or just networking and making connections. I can tell you that anyone can call me 24/7, no joke, if they need my help, because I am that passionate about elevating the level of care for children. Telemedicine is huge. Maybe there's a way you can connect with an academic center that's actively doing telemedicine to help you out. I think there's a huge realm for that. Finally, I'm going to talk about complex solutions, which is where I come into play. So I started this program called COMET, Community Outreach Mobile Education Training, back in 2010. I'm not going to go into the details, but it basically was centered on community partners transferring patients to me. And when I would have calls with some of these transferring facilities, I'd say, hey, why don't you do X, Y, and Z? They'd come to me. I would hope that it had been done and it wasn't. And I was curious and I thought, do they not trust me? Are they not comfortable? And so that's how I sort of started COMET. It was more of a curiosity. Let me bring the simulator on the road. Let me work with these teams and let's see what are the gaps? What are the issues? How can I help them? And so what I do now, this program that we're talking about today is my passion, pediatric emergency medicine, but we're actually a custom tailored simulation group that really looks at individual sites. A lot of places do a one size fits all approach to medicine. No two places are alike. Your critical access site in rural Florida might be different from something in Western Mass, might be different from a place in Oklahoma. What are your pain points? What are you seeing? What keeps you up at night that might walk through your door? What are the bad sentinel events that you potentially have had, and how can we mitigate those going forward? We create an expert team with a curriculum tailored to your needs and come to you where you actually practice. It's all about in situ simulation training with a physician and nurse educator coming with two different lenses, two different perspectives to work with your interdisciplinary team. We bring mock medications that you're going to have to drop in real time. We bring high fidelity simulators where you can intubate them, put in chest tubes, put in lines. We expect you to give medications, fluids, blood, perform actual procedures, whether you are needling a chest, whether you are putting in a chest tube, whether you are intubating, even needle criking, you are doing it all in real time. And in that light, working with your team, we are looking at your system. Do you have the proper equipment? Do you know where it is? What are your policies and procedures that you would use on a regular daily basis? Do they work for you? What are the barriers to the care of children? What are the biggest issues that you're seeing? And so we come to you with the team. We bring everything to you. You don't have to go anywhere. It is more powerful to be in your system with your actual team and figuring out what works, what doesn't. Do I like where the code card is? Do I like how it's stocked? Does it have what I need? Does it make sense? Is there stupid things on it that are just a barrier to care? And I'll give you a couple examples. We've had places where they don't know where the McGill forceps are, nor do they know how to use them. We've had other places that have an emergency airway box. You open it up for a critical event in a kid, and it is a mess of stuff. You can't navigate the box. You're panicking about it. You're not going to be able to provide the care that you need. We help make the system work for you while providing the education and the training. We have a team of endless experts. I have pediatric anesthesiologists, pediatric ENT, adult docs, trauma surgeons, a pharmacist, RTs, nurses, all as part of my cadre of faculty. If there's a question I can't answer because I don't know anything, I get back to you with the answers, and it comes from my expert team. The power of in situ simulation cannot be underscored. We have helped so many listen to me, so many systems transform. It's not a one and done deal. It's a longitudinal relationship where we are an ongoing resource to you and your site. We've been going to some sites for 10 years. I have watched systems evolve into a very unpediatric ready place, if you will, into a high functioning resuscitative team structure. And it's a process. It's not we come there and everything is magically fixed. It's a process. I just got back from Oklahoma, and we've been going to this site for 3 years. And I got a text yesterday. It gave me the goosebumps. And a 5-year-old child was shot in the neck and unfortunately did not have a good outcome, which I don't think is unexpected. But the email that I got from the medical director about the nurses were dialed in, the room was efficient, people were focused on the task, getting pull blood in as quick as possible. And everybody walked out of that room feeling like my recent program there and over the past 3 years has transformed them into knowing how to take care of a critically ill kid and respond with efficiency and effectiveness to feel like they have done everything they can. We don't always get the best outcomes. But I get these feedback emails on an ongoing basis, and they're mind-blowing because every site can do this. You just need the time and the resources and the ability to have these programs come to you. And I can keep going on ad nauseum. One of the things I'll just say one more thing that we do.
Yeah.
We don't just come and do a debrief in real time and answer questions. We actually, we video record all of these simulations. And I watch all of these videos. I spend all of my free time watching everybody else do sim. And we, as a team, go through and things we don't catch in real time, we catch on the video. And we write a comprehensive report that goes through each scenario, what you did, what the goals and objectives were, what we would hope to see. We give you cognitive aids. We give you resources, suggestions. We take pictures of your room, your code cart, how your equipment is set up. Cognitive aids you may or may not have, and we make suggestions about how to improve your system, how to make it work for you. And that's what it's all about. And I have seen so many success stories. One of my colleagues is actually on the webinar as well, Marcy Gowell, who is a DNP and an MSN and a brilliant simulation specialist. And she can also attest to the fact of many of these places that we go that are now impressive places that you would bring any critically ill child. And you don't have to be an academic center to do it.
Yeah.
I'll shut up now.
Simply amazing. Barb, you know what's fascinating to me is that I was reading something online the other day where if your hospital system buys Epic, right, as the EHR, they send in a team of people who embed with you to help you learn how to document, right? But then for this pediatric thing or this resuscitation thing, you're supposed to go to a class every 2 years.
Yep.
And magically, walk over to the cart and push on the mannequin, and magically you're going to go and learn how to help a choking child, a kid with severe croup, a kid with sepsis, a kid in cardiac arrest, a kid who's a traumatic arrest. It just, we do need to put these types of resources, and the program that you've developed over many, many years is truly incredible. You have such an amazing background to prove it. We're so happy that we are collaborating with you now, and hopefully together we can change the world.
I'd love to sort of piggybacking off that point that you just made, Peter. I think this is one of my favorite analogies, and I can't take credit for it, but I want people on this call to think about it. Peter just said, PALS is every 2 years. What happens to our skills with time? Within 3 to 6 months, they decay. If we don't use them, we lose them. And I want to just put this food for thought. And this is where simulation comes into play. This is where practicing your skills over and over again and thinking about how do we make the system work. What do professional athletes do? Whether you love baseball, football, soccer, what do professional athletes do every day? If you think about a baseball player that gets up to bat, they take practice swings. And do they swing half-assed, excuse my language, or do they make it as perfect as they can? They're professionals. They practice perfectly every day. What do we do as ER physicians, EMS providers, nurses when we get to work each day? We maybe get a cup of coffee, we log into Epic, chit chat with our friends. But do we think about practicing perfectly, and do we do it? Do we implement it?
Right.
And that again is where simulation comes into play, and doing it right, doing it with your team in your system. And so I just put that out there because there's different ways to practice and keep up these skills, not always doing high fidelity simulation. I say a very silly thing. Take your team once a month, I don't know, every quarter. Go into your trauma room and have a scavenger hunt. Make it about a little vignette so that you're thinking about the clinical context and what things you might need, and you got to go find them. Make it a contest. Who's going to win the scavenger hunt? And that's going to keep people thinking about how things are stocked, how they're set up, what they have, what they don't have. We can practice perfectly and still have fun.
I love it. I love it. And you're exactly right. The scavenger hunt's a great idea. So now I'm going to go over to another one of my very good friends who is, he's humble. He doesn't like to talk about himself a lot, but we need to brag on him a little bit here. So Dr. Kerry Bachista is not just an EM, but he's also an EMS physician up in the northeast side of the state, St. Johns County Fire Rescue, pretty big agency up there where he's doing amazing things, and also is an emergency room doc at the Mayo Clinic in Jacksonville. Why I have Kerry on today, and Kerry, I'll take off my slide so you can share yours, is because you have led the state in this concept of resuscitation centers of excellence. And this is it's like lit the state of Florida on fire in such a great way. And I wanted you to talk a little bit about that, and then talk about this next concept that you're spearheading. So my friend Kerry, take it away.
Thank you, Peter. Yeah, I'm going to talk about what we're currently doing here to let people in on what we're doing here in the state of Florida, and then some of the history of it, and then we'll talk about how what we're planning on doing, what the future looks like. So this past year, the state of Florida has begun a self-attestation process for hospitals to go through a series of process improvements to become certified as either a primary or a comprehensive resuscitation center. It's a list of standardized criteria, order sets, required specialists that need to be in-house, and just all of these processes to improve the level of care that we have for cardiac arrest and post-cardiac arrest patients within the state of Florida. So the history of this comes before 2020. Some ER doctors, EMS leaders in the state, cardiologists, all got together on a sort of an informal, impromptu conference day to discuss what is the standard of care, what is the status of cardiac arrest care in the state of Florida. We met for a day. A lot of things were discussed. Different EMS systems discussed what they were doing. Cardiology kind of talked about what some of their was going on in the state of Florida. There was some socioeconomic discussions, but I think what came out of it was a couple of key things. Number one, we could do better as a state, but then number two, we just had these wide disparities in what the levels of care are throughout the state, because as a state, we're very large. We have very urban areas, we have very suburban areas, and we have some very rural areas. And some of them, as you discussed in your earlier story, some of them butt up against each other, right? You have Palm Beach County has some very rural areas, some very outlying areas. And so the state kind of encompasses all this. And what can we do to start to improve the level of care we have for these facilities? So we looked at what we can do at the pre-hospital level. And the goal of this was to establish a system of care. And we looked at the trauma centers that we have. We looked at the stroke centers that we have. And what can we build off of that foundation and see what we can do for resuscitation? So we came up with, a couple of years ago, we came up with the criteria to become resuscitation centers. We broke it up into primary resuscitation centers and comprehensive resuscitation centers. A primary resuscitation center is probably going to be your standard PCI level facility. They're most likely going to meet the criteria for a primary resuscitation center. And we started at the beginning. We started at the entry point to the facility. When that patient comes in, cardiac arrest with or without ROSC, we started that entry point and we said, what is every point that as that patient goes along through their level of care, what's every point that we can look at and we can improve? And we looked at things like objective termination for resuscitation. What are the standardized order sets that can be employed in these areas? Protocolized consults, different levels of care to kind of bring everybody as a team to these patients that need resuscitation. And then working with the EMS agencies that are primarily doing the initial footwork on all of these cardiac arrests and hopefully getting ROSC on them and bringing them in. And then data collection in the background through the cardiac arrest registry to enhance survival. These primary resuscitation centers are going to have PCI and ICU capabilities, different subspecialty services. There's standards for neurologic care. All of this is evidence-based. All of this is probably what most hospitals are doing. It's just a way to sort of set the goal, set the metrics, and be able to QA these facilities as they go along. So then we have comprehensive resuscitation centers. It's basically all the primary resuscitation centers criteria. And then mostly your ECMO centers, right? Your places that are doing in-house ECMO. There's some research and outreach requirements and some other community-based teaching and other outreach requirements. We started this year through the Department of Health and the Florida Association EMS medical directors. We already have multiple facilities that have signed on and become certified as resuscitation centers. I left the QR code there to scan for more, and we can add the page later on if you guys want to see that. But then once we got that going, we thought, what else can we do? Can we do stuff with pediatrics? Can we do stuff with some of our rural hospitals? And we got back to remembering what the goal was. The goal of this was to increase the level of care for patients throughout the state. And while the primary and comprehensive resuscitation centers is going to be mainly your urban and suburban core areas, we have a lot of rural and underserved areas in this state. What can we do to sort of develop something to improve the care for those facilities? And so what we looked at was the statutory rural and critical access hospitals, and we said let's build some criteria, let's build some procedures that will help them to improve the care in these areas. We're developing this now. This is something we're starting to look at with the goal of hopefully developing something. And we looked at, what training can we bring to bear in these facilities? What sort of equipment should these facilities have so they're ready for these resuscitations? Can they utilize some standard order sets and some of these objective criteria that the more urban and suburban primary and comprehensive resuscitation centers do? We looked at these facilities will have partnerships with other resuscitation centers throughout the state. And then can we bring telemedicine? Telemedicine is huge. Can we bring telemedicine into these rural facilities from some of these comprehensive and primary resuscitation centers to enhance the level of care at the bedside? And then we looked at, we're going to look at things like how can we streamline the process of getting care to these patients? How can we streamline the process of getting them out? And what teaching and other collaborative efforts can we bring with EMS and the facilities so that when there is some resuscitation or a patient that really needs some of these high level care procedures, that we can really get them there and get that to the patient and then get them to the care that they need.
Wow. It just proves to you that this is something that you started on the back of a napkin, right? And then next thing you know,
give away the secrets.
Right, at a bar. No. And then the state of Florida said, hey, this is something that we need to do. And now you're moving it into the rural and critical access care hospitals. And that map of Florida is probably very similar when you look at every other state. When you look at county by county, the number of rural locations that don't get the money, that don't get the support, that don't get the eyeballs on it. And when you drive through those areas or you work in those hospitals, you understand that there's a big deficiency. So there are these deserts. There's OB deserts. There's some pediatric deserts everywhere. So it's really up to us, and to see what you're doing structurally from the state is truly incredible. So,
and I think the goal is the goal has always been to get a network and a system of care together. And now we got to bring the rural hospitals into that and bring that all together. So we truly have a system of care for everybody in the state.
Completely agree. So I really appreciate that. It was a great presentation. And so now I'm going to pass it off to Patrick, who's on my team, our Chief Growth Officer, for the big announcement. So Patrick, I'll have you share your screen if you'd like.
Sure.
And is there a drum roll? Can we do a
Hey, I'll take it. And I'm actually going to pause on the announcement for probably 2 minutes, just because I want to kind of tee up the momentum. I want to keep.
Yeah. Go for it. Go for it.
No, but Dr. Bachista, Dr. Walsh, you guys have done obviously a great session in sort of spearheading some of the resourcing and needs of our rural EDs and EMS across the country and getting pediatric ready. And obviously, our team here at Handtevy, we've been focusing on this initiative for a long time because we truly feel that as clinicians, as paramedics, as nurses, I think we're all fairly competent and comfortable with knowing the science and medicine, right? Why we're giving ABC drug to treat XYZ indication. But I think when it comes to peds, there's that fear factor involved that we're not dealing with these patients as often. We're not as comfortable with them. We got mom and dad there in the background doing complex math. And there's a lot of variables that are happening very, very quickly, which kind of defeat us. And that was my experience working in the field out here in Broward County after meeting Dr. Antevy. That kind of changed my mindset a little bit, of course, because he kind of showed me a new way of doing things. But nowadays, I've been here for about 10 years now. And for anyone that's not familiar with Handtevy, we have been around for about 15 years in total now. We work with over 2,000 EMS and hospital healthcare systems nationwide. And so each one of these blue dots here represents one of our active Handtevy mobile clients. This map, in fact, is actually about a year old at this point. So it's actually grown immensely since then as well. But through this level of success, we've been able to forge great relationships with state EMS for children's programs across the country. They obviously are partners in the Pediatric Readiness Project, helping bring in resourcing to both EMS and EDs across your respective states. And these green states here are states that have worked with us to initiate some of these pediatric resources on both the EMS as well as the hospital side. Now, these partnerships have been so successful that over time, we've actually built statewide adoptions of resources, well, Antevy specifically, in these various states. And our most recent state, drumroll, in the state of Florida. And so to Dr. Antevy's point earlier, the state of Florida is doing exactly what has been recognized in the data sets that he shared. They're spending more money on this now. And so the state of Florida has actually partnered with us to provide Handtevy mobile, pediatric-specific education, pediatric-specific resourcing to any state-designated EMS or emergency department here in the state of Florida. And these counties here in green are those counties that this covers. And so, I kind of highlighted a little bit here already. For anyone that's not familiar with Handtevy, our goal here is really to solve the proverbial pediatric problem. At the end of the day, everything that I just described, Dr. Walsh, Dr. Antevy, Dr. Bachista, I think what it all boils down to is that at the end of the day, we're all human beings by nature. We're designed to make mistakes. And our goal here at its core is to really create standardization as to how we approach all of our patients. And I think, for us here at Handtevy, there's obviously nuances that come involved with treating emergent pediatric patients in the field and ED. We recognize those, we embrace those. But it's our firm belief that the same level of safety, same level of confidence, same level of aggressiveness needs to take place in both the pediatric world as well as the adult world. And if we're able to bring that same mindset into both settings, you'd be amazed at the psychological change that has for your clinicians in the field, because we're doing this every single day and it's building that muscle memory. And so for us to do that here today, we actually focus on a resource that's called Handtevy Mobile. The key takeaway with this organization is that we're designed to create cognitive offload there in the ED. So this is fully tailored towards your facility, your pharmacy. Our entire clinical team here at Handtevy, who is backed by a lot of pediatric experts, they review all the clinical content within this. They make sure it's safe. They'll give recommendations if asked. But it is cloud-based. You don't need Wi-Fi, don't need cellular. There's no PHI, there's no HIPAA. And most importantly, whenever your team has a clinical update, we've changed a concentration, a dose, we removed the med, add a med, etc. Your pharmacy team will actually be able to communicate those changes to your end users out there in the field, making sure that version control remains consistent, right? And through this resource, there's several layers of feature sets that kind of come with it, but one of the most prominent ones that tends to be used heavily inside the ED is something that's called CPR Assist. And really what this resource is designed as is a way to capture cognitive offloading during those cardiac arrest events, where we're now also capturing an enormous amount of data during this care. And so this metronome here is basically built around your team's algorithms, your compression rates, your ventilation rates, whatever setting you're set to, 15 to 2, 30 to 2 or continuous, the metronome will be going off according to that there. But underneath that, you'll be able to see a very brief example that there are medications that will be listed, giving us our dose, concentration, route, and volume. And really all we're focusing on now is the science and medicine. We're not doing the complex math. We're not trying to guess what size of piece of equipment we need. It's keeping us on pace with running these highly acute events. And so we're very excited about this level of partnership. There are additional resources that our team does deploy along with this as well. So there are some durable resources. Again, these are fully customized. They're tailored to your facility, your pharmacy, your equipment, what you guys do out there in the ED. As well as varying levels of education. And so one of the things I think that is important to recognize is that while creating a system of care, using references, resources, products, etc., those are all important. They're successful. I think without formal, true education, we miss out on being able to really leverage that level of resourcing that we just deployed, right? And so one of the things that we focus on during our implementations across the country is formal training on pediatric specific events, where we take a very hands-on, very scenario-based approach, where we're working with mom and dad. We're learning how to divvy out roles amongst crew members. We're covering peds sepsis, peds respiratory, high-performance pediatric CPR, and even pediatric bereavement, a very important topic that I think we seldom ever talk about. But that's important to us as care providers, because at the end of the day, we want to be able to leave an event, whether it's on the EMS side or in the ED, feeling good about the quality of care we gave. And to Dr. Antevy's story that he told earlier about the unfortunate event out in Palm Beach, being able to look mom and dad in the eye and say, hey, I'm so sorry, I did the best I could. That's an important closure aspect to us as clinicians, right? And we need that in our careers, trying to survive 20, 30, 40-year careers in the field, right? But with that said, there's a lot of peer-reviewed data out on the effects that resourcing like Handtevy brings to the table. We'd be more than happy to share these data sets with anyone that is interested. As well as also offering access to a demo environment of Handtevy Mobile. If anyone wants to access it, there's a QR code there. You can download it, play around with it, get a feel for it. But afterwards, we'll have some follow-up resourcing with some links and things like that to access as well. But Doc, I didn't want to take up too much time, so I'm going to turn it back over to you for closing out.
Awesome. All right, Patrick, that was incredible. I am going to just end it with a couple more slides. Let me just remove the spotlight. Okay. So I know, Patrick, you showed a couple of data points. I'm going to show a few others. Landmark trial in 2022. This looked at folks who were using the Brazil tape beforehand, and then they switched to Handtevy. These are real patients. These are not on simulated patients. So this was a very big study out of Denver Health. And then the other one came from a pretty rural area in Polk County, where they actually demonstrated a significant improvement in outcomes, a significant improvement from 0% survivors to 23% neurologically intact survivors. And then when you look at the years following, all the green, these are kids who are walking out of the hospital, and year after year, they have maintained that standard. So it doesn't really take a lot. It does take some resources, education, training, and then the customization that we provide with Handtevy Mobile, I think, is the key. I wanted to end with this. And when you work collaboratively with your hospital, so if you're an EMS clinician on the call today, or if you're a nurse or physician on the call today, what I would like to see happen is we all come together and train. And I'm going to show you a video here of what we now do. And, Dan Moran, who he and I did this at many hospitals over the years, but we actually take our EMS team in, and we will actually do pediatric cardiac arrest training on the floor. So
that's the metronome you're running in the background.
1 ml, shocks are at 50. Baby. I know it's 1.5.
All right, I got no fault for infection here. We have a 1-year-old.
Okay, good. So you'll see he strategically placed his medications down here because he's going to be working on the IO and the distal femur area. Okay.
So I'm going to stop this, and just so you can see that we're in the emergency department on the floor, all the nurses and all the doctors are there. And then what we do, if I fast forward this a little bit, is that right at this point, we say, you know what, we're going to practice the handoff. And if you've never practiced the handoff before, listen, and you'll see it goes from quiet to we transfer care to the hospital bed, and then all of a sudden the noise level goes way up. This is the very first time we were doing this. As we did multiple iterations of this, similar to what Dr. Walsh does, the noise level goes down. All of a sudden people stop yelling and screaming and panicking because you've done this. You're like a professional athlete. So take a listen. Here's the handoff. My favorite part.
Epi was given about 3 minutes ago. We have an IO established. Size 1.5 eye gels in place. We're getting good back compliance on it. The end-tidal CO2 is at about 10 centimeters.
Ready?
Now listen to this.
2, go.
So unfortunately, a lot of places, they'll take out the airway, they'll disregard the distal femur IO. They have a $35,000 monitor sitting on that bed, and they're going to rip everything off. And we said, no, don't do that. So now we leave everything in. We focus on the BLS that matters and the ALS aspects that matter most. And this is how you make a difference. And so the last thing I'll say is that the state of Florida has tried year after year, and you'll see this at your state, is that Florida laws do not require hospitals to meet minimum standards for care for pediatric patients. This is the bill that was put in 2 years in a row, didn't pass. This will pass. And every state will have laws that will say you must have a certain score on pediatric readiness to be a legitimate hospital in this state. And we'll celebrate when that day occurs. And all of us will have better outcomes for our kids and our relatives and our friends. So we appreciate you joining us today. There's the QR code for CE credit. And also, Dan will put a link if you're interested in learning more about what we do. If you're a rural hospital or EMS system in Florida, then you should definitely use that link in the chat. But if you're a hospital out there who wants to learn how to get in touch with us, how to collaborate with Dr. Walsh and her team, we are all going to be working together to make this effort, which is going to be another decades-long effort, I'm sure. But that's what we're here to do. So we thank you all for joining. And we're only 2 minutes over the hour. Wow. And so, Dan, I'll have you make some final comments, and then we'll open it up for anybody who wants to stick around.
We saw a great engagement in the chat, a couple private messages too. So I want to thank all of our speakers for being here, and thank all of you for attending. At Handtevy, we believe every hospital can be ready for kids, no matter the size, no matter the location. And if you want to take the next step in your pediatric readiness journey, we'd love to partner with you. The link that we put in the chat, handtevy.com/peds-ready, will allow you to fill out a brief questionnaire just so we can get some information from you. And then our team will reach back out to you, whether you're interested in simulation, sample protocols, etc. We have a great program in place that can help you prepare for your next critical child. So again, together we can make sure every child gets the care they deserve. And we want to thank you all for attending today.